a very warm welcome to the next webinar of the South African Learning Alliance for the District Health System. Krish, please take us away.
Thank you very much, Sue. So good afternoon, colleagues. My name is Krish Vallabhji, and I've been asked to co-facilitate with Professor Susan Cleary. So really welcome to you all. It's really great to see so many people join. We're more than 50 people already, and some people are still joining, but we must get started in the interest of time. So the topic for today is really working with and for communities, building trust and strengthening the DHS through community engagement. So I'd just like to spend a few minutes trying to set the scene before we get stuck into the meat of the webinar. Community engagement or community involvement, community participation, call it what you will, uh, has been an important principle of primary healthcare right from the outset, right from the 1970s and probably beyond, uh, as a key element of primary healthcare. And when it was enunciated as a pillar of primary healthcare, it was meaning that communities are not just passive recipients of health services, but they should play an active role in the provision of health services, in the designing of health services, in holding services to account, etc. So it was a much more holistic concept. Community engagement is also part of our constitution. It's part of our National Democratic Plan for 2030, which talks about deepening the democracy in our country. It's part of our developmental state, which is meant to be accountable, transparent, responsive to community needs. And if, as a state, as a government, we are meant to be responsive to people's needs, it's important that we understand those needs. And understanding those needs is not just about epidemiology or statistics or all the hard quantifiable stuff that public health specialists do. It's also about understanding the context. It's about understanding the lived experience and the lived reality of our communities. So that's a hell of a important, and it's not a once-off event. It's a relationship with communities. Now, so the principle and the strategic intent is well established, I think, over many years, locally as well as globally. In the topic, there's a big word there called trust, and trust is about confidence, right? It's about confidence in the public services. And that confidence has two main kind of ingredients. The one ingredient is about the character, and that refers to integrity, it refers to transparency, openness, etc. And the other ingredient is competence and ability to deliver on the mandate to provide services, the track record of being responsive to people's needs, etc. So those are key elements of trust. And trust is a big word, very palpable, very important to be present. So that's in terms of principles and the strategic intent. But all said and done, context matters. And context is also not static. Context is always evolving. Now, we are 31 years since our democratic elections, and we have made enormous strides on multiple fronts, including improving health outcomes, the ARV program, access to healthcare, and many others. That's on the one hand. On the other hand, it is also true that we are one of the most unequal countries, if not the unequal country in the world. We have one of the highest unemployment rates. We have large sections of our population living in poverty. Food insecurity is getting worse. Basic services are not being met for significant portions of our population and the like. And that includes the quality of health services. So that's the kind of context we face. When it comes to trust, especially trust in government, there's a huge trust deficit, and it's understandable because of all the mismanagement and corruption and failure in service delivery in many counts, etc. So, when I speak about character and competence, I think on both those fronts, there are reasons why there's a huge trust deficit. So we, over the decades, we have made numerous attempts about community engagement, and those attempts have come from the state where legislation has been passed, and we all know about clinic committees and hospital boards and district health councils, etc. So a large part of that is very compliance driven. But there's also civil society-led initiatives, and those are quite important, like community-led monitoring and the like. So we're not starting with a clean slate. So the purpose of today is really, having said that the policy and the strategic intent is well established, the purpose of today is to try and focus on some real life experiences and projects on the ground, and learn some lessons from that, of what actually has worked, what are the challenges in that regard, etc. So that's really where we are. We've got a great program and four very good speakers. And I'm going to hand over to Prof. Susan Cleary, who's the head of public health medicine at UCT, to introduce the speakers and to facilitate the rest of the conversation. I will come back towards the end to try and summarize some key messages. I also want to really encourage you, as many of you might have had your own experiences regarding community engagement. So really to share that. Time in these webinars are always limited, so please use the chat to make some comments or share your ideas as well. And all of this will make for a very rich webinar. So thank you very much for making the time and joining us. Susan, over to you.
Thank you so much, Krish. So we are going to start with inputs from our first three speakers, and I'm going to introduce them just before they speak. So I'm going to introduce the first speaker, and then we're going to hear from them, and then I'll introduce the others. And I'll also remind us of the questions that we put to our speakers. So we've asked them about their experience of working with communities to improve health and being. We've asked them what did they think they did well and why they think it went well. Also, what were the challenges and how have these experiences contributed to building sustained trust-based community system relationships? So those are the kinds of questions that we asked our speakers to reflect on, and we're super excited to hear what they thought. So starting with Melikaya Soboyisi, who is a public health professional with experience working at the intersection of research, community systems, and HIV and TB program implementation in South Africa. He currently leads the community-led monitoring program at NACOSA, supported by the International Treatment Preparedness Coalition. In this role, he works closely with communities to generate evidence, amplify grassroots voices, and improve service delivery through accountability. Thank you so much for joining us, Melikaya. Over to you.
All right, thank you so much, Prof. Susan, and Prof. Krishna. Thank you for laying such a important foundation. So I'll be speaking about the community-led monitoring program, which we have been implementing, particularly in the Western District. So this would be in Gauteng. So if I can just have the next slide, please. So with the community-led monitoring program implementation, this was an implementation that came up by community and for community, and it was during a very crucial time of COVID-19 pandemic, where the purpose was to monitor the impact of COVID-19 on HIV and TB services, particularly putting attention to the prevention services. So in the Western where we were working in 15 health facilities in Mohale sub-district, Rendwe sub-district, Merafong city sub-district. Also, because the program started in December of 2020 and ended in December of 2024, there was an opportunity to look at some of the intersections between HIV and also gender-based violence. So During the last year of implementation, that's where we looked at services that are being provided by the Clinical Forensic Medical Services Centers in the Western District, looking at Leratong, Bakersdale West, Carltonville, and then also an opportunity to monitor some of the HIV and TB services that are being provided by non-governmental services providers, which would be Rotanganetsa Community Care, which is a PLHIV-led organization, Tshepo ya Bana, which is a people who use drugs led organization, and Bituta Lesedi, which is a stigma reduction led organization. And with all of this, we had 19 data collectors, of which we called field researchers, and they were supervised by 2 people. And then also, as I said, this continuous monitoring started in October of 2020 and ended in December of 2024, where we monitored 20 plus indicators, which included qualitative and also quantitative indicators. Next slide, please. So part of the model in which we were using to implement this was using the International Treatment Preparedness model. So it forms over 4 quadrants. So this would be 1, education, 2, evidence, and then through evidence, evidence, engagement, and then advocacy. So through education, this was important in terms of learning about the science behind what is it that we are trying to do. So this is where importance of grassroots consultation with the Department of Health, with the district AIDS councils, with the civil society forum leaders, and also the community implementers in having to understand all the indicators in which we're trying to achieve related to HIV and TB prevention, particularly for people, for key and priority populations. So through that process, once we had our 19 field researchers, we collected the data through the facilities and also some parts of the communities where this data now was both collected quantitatively and qualitatively. So by quantitatively, we mean there was some surveys that were directed towards the receivers of care who are accessing services from at those said facilities. And then also another part of the quantitative data was being provided access to the district health information system to data in having to understand just the population dynamics and HIV testing dynamics within all those facilities. And then from there, on a qualitative point of view, through focus group discussions, we were then able to generate a further elaboration as to why are we seeing certain trends that we are seeing. So that is basically coming from the point of documenting the community experiences in terms of how they're accessing services. We compile this information and then we start to engage. So through our engagement, the engagement involved what we call a community consultative group meeting. So within this meeting, we would then have the district district health management. We would have the district AIDS councils who would also be coordinating all these engagements because it is part of their mandate in having to coordinate HIV and TB related initiatives in the district. And then from there, with the presence of clinic committees within the various districts, and then also having to engage the civil society forum sector leaders and also their members as well. And then from there, in having to speak about the gaps that we would have identified, that's where now co-creation of solutions and advocacy initiatives actually came about. So I'd like to maybe share on my next slide some of the key CLM top line achievements that we actually encountered, which is one, when we started the program in 2020, I think the PrEP initiation was quite significantly low in the West Rand. And I think through demand creation and also co-creation and having to share some of these gaps with the Department of Health, we then found that through our CLM cycle, which basically takes 3 months or rather quarterly, following prep-related CLM feedback sessions with the facility managers, people who visited our 15 monitored sites were 32% more likely to initiate PrEP following an HIV test compared to the other 14 Western health facilities. And then not only that, when it came to being able to reach men, we found that the percentage of older men living with HIV who know their status has increased from 86.8% in 2022 to 88.9% in 2023. And this was following a CLM data-driven campaign to increase community-led HIV testing from 20.4% in 2022 to 33.6% in 2023, therefore surpassing the UN target that was achieved. And then also when it comes to the after using CLM data to alleviate stockouts of TB medicines, the treatment success at our CLM sites increased from 88% in 2023 to 91% in 2023, surpassing the end TB target of 90% 2025, as well as the South African national treatment success rate of 79%. Also, one of the top line outcomes that we found was that enhanced patient tracking for pregnant foreign nationals was implemented based on the CLM insights in 2023. Women at our monitored sites were twice as likely to deliver in the health facility as compared to other Western health facilities. So due to constraint of time, I think I'd love to leave my presentation there. I'm happy to continue the conversation on the chat, and thank you so much for the opportunity.
Thank you so much, Milikai. That's absolutely fascinating. I don't know if I've ever seen that before, of seriously improved uptake and potentially outcomes following such an initiative. So thank you so much indeed. So our next speaker is Motlatso Lechokgola, who is the District Executive Manager of Capricorn District in Limpopo Province. He joined the Department of Health in 2004 and was previously the CEO of Bela Bela District Hospital and Boitumelo Regional Hospital. Thank you so much for joining us this afternoon, and we look forward to hearing your thoughts. Over to you.
Thanks, Prof, and the colleagues on the platform. Indeed, my name is Motlatso Lechokgola. I'm going to take you through the presentation. I'm currently the District Executive Manager of Capricorn District. The outline of my presentation is I'll take you through the background of the province, slightly, just in brief because of time. I'll also look at the enablers for strengthening community system relationships over time. I'll also look at the constraints in community system relationships over time, and then I'll conclude. Next slide. Next slide. Yeah, like I've indicated, in terms of the background, we are locating the presentation in Limpopo Province, which is predominantly rural in nature, where majority of the health facilities are located in traditional areas. I am not going to bother you with the definitions of community, which is just a social unit, sharing an important characteristic such as norms, culture, religion, values, customs, and identity. We also got the formal as well as formal and informal or urban, rural, global, or sectoral communities. And the business practice characterized by development of a mutual beneficial community partnership within the area in which an organization operates. And there are three types of community relations. That is symbiosis, where people are benefiting from living together, predatory, and competition. Next slide. Next slide. Now, in terms of my experience of working with communities or engaging communities, the first thing that I want to talk about is the issue of community engagement protocols. I've indicated in my opening that Limpopo is rural. in its nature, and majority of our facilities are located in those rural areas where they are found within the chief crawls in the main. Therefore, when we are to talk about protocols, the first thing is that just communicating is very important issue in terms of directing our correspondence or who must call that particular crawl if you want to go and engage with your facilities. The next thing that is very critical is the arrival time that needs to be observed. When you go in communities, if you say 10 o'clock, please make sure that you are there before that time. Otherwise, if you arrive late, that is going to affect the trust relationship with that particular community. The other issue is the issue of the dress code and greetings. When you go and engage communities in rural areas, the most important thing that you must be mindful of is your dress code. Men are to have to wear jackets, for example, and females, they are expected to cover their heads and to cover their shoulders. They must put something on their shoulders. If that is not done, the trust relationship is affected. The way you greet and the language that is used is very important. When we go to these communities, we look at ourselves and we look at the best individuals that can relate well with this communities. They can greet because there are sub protocols within the big protocol of saying how do you talk to the chief or how do you talk to the people that are representing that particular crawl, and also the language. You can't go there and expect to speak in English while the majority of people that you are going to meet, they are speaking Soto or Venda or Shangaan. You need to be to their level. There's also an issue of protocol that is associated with the lodger fees. In other words, you don't go to communities barehanded. There's something that you need to have, whether in money or in kind, when you go in that particular community. And then if you observe all these protocols, you begin to strengthen your relationship of trust with such communities. Next slide. Yeah. Here I'm going to just give you one example of where when you engage with communities, particularly their demands, what you need to do. In other words, I'm saying
Are you okay, ma'am?
As you engage with these communities, you need to balance the demand and the available resources. It doesn't mean when you are going there, you must go and overextend yourself on issues that you cannot achieve. Because if you do that, the relationship that you are intending to establish, it gets destroyed. It's better that, for example, if we're talking about the communities engaging you on clinic operational hours, in the main, our communities, they want their clinics to operate 7 days a week or 24 hours. Therefore, in most cases, is that our available resources don't meet that, but then you need to go there with an open book kind of a situation where you'll be telling them about the head count of that particular clinic, the staffing, and the distance between health facilities. Because there are times when the chiefs, they are competing amongst themselves. The one chief is needing a clinic to operate 24 hours, while just 3 kilometers away or 2 kilometers away, the other chief also is expecting the same. Therefore, in that instance, you need to open up and explain to them to say, this is doable, this is not doable, as opposed to you saying all is doable, and at the end of the day, you are unable to fulfill that, and therefore you'll be setting yourself at the back foot. Next slide. Next slide. Yeah. The other issue that is very important for us to solicit trust in communities is the issue of participatory engagement. I think Prof, when he was laying the foundation, He indicated the issues of the communities that are there. And then what is key is that broad engagement will lead to multidisciplinary engagement over time, and strengthen feedback. Yeah, maybe let me put it here. I'm prepared to continue on the chat. Thank you.
So you're still muted.
Ah, hallelujah. For a long time, the host was not allowing me to unmute. So I'm super relieved that I now have a voice again. So thank you so much for that. That was absolutely fascinating and really ties in with something that really resonates with me and that I find a problem in South Africa is our tendency to overpromise and underdeliver. So I really love the message of going to communities and being honest about what it is that we can do. Otherwise, we destroy trust. I thought that that was a fantastic message, and thank you so much for sharing that with us. So our third speaker in this section is Christine Jansen, who is a highly committed and experienced community leader and activist. She serves as a member of the Manenberg Health Committee or Forum and as secretary of the Klipfontein Subdistrict Health Forum. She is described by her peers as a long-time and very committed activist, adult educator and organizer, and is a critical voice in community health advocacy. Thanks for joining us this afternoon, Christine. Over to you.
Okay, thank you for that. Can I have the next slide, please? Slide, Clarissa.
Yeah, the slides move a bit slowly, so I think that they're coming.
All right. Yeah. Okay, so the national, this is a background. The National Health Act of 2003 makes provision for the establishment of clinical committees at health facilities. The different provincial health acts spells out how that engagement must take place. So we're coming from an activist anti-apartheid struggle background into a legalized space. So it was from confrontation politics to learning to engage and to negotiate and lobby for change. Next slide. So our initial experiences was that we were met with antagonism from facility managers and staff, contempt, no trust. It was about common people telling learned officials how to do their job. So it's like we coming to take over the health facility. Training was the responsibility of the Department of Health. We had one training session in 3 years, no ongoing training on changing policies and laws. Inequality in knowledge. Committees are not fully aware of their roles and responsibilities, and this lead to committees being led by facility managers and local councillors, and we just become a box to tick. Next slide. So we formed our own sub-districts and our own community health forums so that we can share our common challenges and strategize on the way forward. We had partnerships, still have, with progressive academics and organizations like the People's Health Movement in our own search for knowledge. For example, simplifying the national and provincial health acts, roles and responsibilities of committees during COVID-19, and now the National Health Insurance, when none was and is not forthcoming from the Department of Health. With the NHI, we are working with UCT through the Complas project, that is a community participation in the context of plural health system. It's a research project and includes capacity building of health and clinic committees, and also aims to capacitate healthcare workers. So we have community site coordinators that see that the community voice is heard throughout this process, and we are also co-creators of knowledge when it comes to training of clinic committee members. So the ideal clinic concept, the national policy to manage complaints, compliments, and suggestions, the whole of society approach, and the COPS, area-based team approach in the Western Cape for primary healthcare. This allows facility managers and staff to have to work together with clinical committees and be held accountable. Parliamentary portfolio committees to lobby for change and right submissions. Next slide. So we need a common vision for participation. We must be involved in the planning, provision, evaluation, and monitoring of health services in all levels, right? We mustn't just be given a worked out plan and then afterwards being asked your opinion, which is not taken seriously in any case. So working together on joint campaigns, small victories showing faith from both sides, and they are currently that levels of trust are increasing, but it is work in progress. Facility managers to be instructed to attend any training together with community committee members. Next slide. So currently, the UCT Complex colloquium on how to increase community participation within a plural health system under the NHI. Working with Complex to submit comments on recent NHI regulations on advisory committees. Current efforts to have a national policy on health committees accepted, stemming from a national clinical colloquium of health committees supported by the People's Health Movement. And those were the days in which it happened. And we also have a link where you can sign our petition online. There's a short video on clinic committee views on increasing community participation. Slide. And these are the efforts to have this petition signed nationally. And I think this is the end of my presentation. Thank you very much.
Thank you so much, Christine. It was very inspiring to hear your efforts in including on things like making inputs on the National Health Insurance regulations. I'm hoping you're making an input on the stakeholder, I think it's called the Stakeholder Advisory Group. I think it needs quite a few inputs as well. And I also really like the idea of facility managers and clinic committee members doing training together. I think that that could be really powerful. So thank you, Christine. And thank you to all three of our speakers so far, bringing some really interesting and diverse inputs from different parts of South Africa. And now we would like to hear from our audience what your thoughts are. And so we have two potential questions for you. The one has been, what has been your experience of working with communities to improve health and well-being? And the other is, what has been your experience of less constructive engagements that threaten community trust in the district health system? And how can such situations be avoided? So you are most welcome to put your thoughts into the chat. But what would be even nicer is if you added your voice out loud into the webinar. You can unmute yourself. You can turn on your camera. That would also be lovely. I'm just having a look at the chat. Melikaya, perhaps you want to add a bit more in terms of your comment on trust that you made in the chat.
Okay, thank you so much, Susan. I think what I was referring to in regards to trust was most often community engagements, or rather external partners that want to partner with the department, they often do so with perhaps maybe coming with certain money that can be able to assist the community. But most often, the community members themselves, the Department of Health, do not have a understanding of how does this also assist us from the national strategic plan, and especially at the district level. So in having to educate the partners and also allow the department to also educate the community based on how we are supposed to do implementation. That was one of the greatest buy-in that we were able to get. But not only that, but I think from the community managers themselves, I think at first this initiative came in to seem as if it's a fault-finding initiative. But when they saw that as a community, in having to consult with them and actually follow due processes, and then having to co-create solution together, and having to see the results in how that actually came about, that really did build trust with not only facility managers, but the communities as well, in having to use some of the community-led monitoring insights to improve on the community initiatives.
Thank you very much. And Motlatsa, maybe I could ask you to respond to some questions in the chat that are to you. I see that you have written in the chat, but it would be really nice to rather hear your voice. And so the one question was about cultural sensitivities and what happens when the official person that goes to the communities is not the right fit. And the other question was about how we need to think about tailoring our responses to communities as opposed to expecting it to be the other way around. Would you like to comment on any of that? There you go. Go for
Yeah,
it.
thank you. Yeah, I think like I've indicated on the chart that if an employee is found to be not fit to engage the the community, they get assisted as to how best to do that. And then if they successfully or unsuccessfully fail to do that, then they get redeployed. But I think what I wanted to say was that through the feedbacks that we get, through the feedback loops, we are able to assess ourselves and make sure that we assigned proper people that are relevant in terms of observing those protocols in those particular communities. It's very rare that we can assign somebody that will ultimately not be able to feed with that particular community, because it is, we are taking that process very seriously, because it's a thoughtful process as to who can communicate, how do they communicate, and then how do they observe the protocols. It's seldom that we get people that are unable to engage with those communities.
Mm. And am I correct in understanding that you use data sometimes to explain why a certain service could not necessarily be available or could not necessarily be available 24 hours? You had a slide that mentioned headcounts. Could you tell me more about that?
Yes, I think it falls under the balance between the demand as well as the available resources, that data is very critical in terms of saying what is the head count of that particular facility, how many patients are seen after hours, how many patients are seen in a month. because sometimes the demand is not commensurate with with the need or with the real problem on the ground. And then when that is analyzed, we get back to the community. We get influential people in the community, and then we start engaging with them to say, yes, we see this is what you want, but we have looked at our data, and the data don't support that particular kind of a demand. And then they become realistic, and we come to a amicable conclusion on that particular matter. But the most important thing is that you open the books, you show them what is actually happening. And then if you can even challenge them to say, let's go there and see, let's open the books together so that at least you take decisions on the basis of data.
Mm-hmm. Thank you so much. And Christine, I was wondering if there's anything that you would like to add from your experiences of.
Yes.
Please go ahead.
In terms of the involvement in the district health system, in the Western Cape, we have Western Cape District Health Councils Act. Absolutely no provision is made for the participation of hospital boards, clinic committees on this district health council. The only level of participation is at the local clinic committee level. There are no local clinic committee level. Like I said, we had to form our own sub-districts, which was clearly, we were told, is not officially recognized by the health authorities, and we had to form our own Cape Metro health structures where committees, because what is happening here is that communities are isolated, you're isolated across the country, and there's no mechanism for bringing us all together to come and share our experiences and our challenges. And the complaints, it's always mostly the same. So the legislation is not, how can I say, really people friendly, because they speak community engagement, but do they practice? So like I said, they come with already prepared plans and ask your input. We want to be part of that plan.
Thank you, Christine. Jenny, I see your comment in the chat, and perhaps you actually can answer that question given your experiences. Would you like to speak out loud?
Thanks, Sue. Good afternoon, colleagues. So I really appreciate the presentations, and I think especially, and I see in the chat it's come through again, it's just that, that need to build relationships and build trust, which is so important. And I think sometimes the healthcare workers, we sort of parachute in, and we think that just by proposing something and everything's going to be fine, and we don't really take the time to build relationship and hear what people are saying and thinking. But I just wondering when sometimes politics gets caught into this, and I put in the chat a situation that we had fairly recently where it was a small community and there seemed to be two political factions, the same party, and they were both vying for support, and somehow the hospital got caught up into this, and so community members were targeting the health services to try and make a point and try and force health to make decisions which either supported the one faction or the other. And it got really, really nasty, and the whole community got caught up into it because vehicles were being burnt, and even trucks just passing through the town were being torched. And I'm just so aware of the sort of delicate political situation that we sometimes face in communities. And so I just wondered, you know, and that the team at the hospital had been there for a long time. But as soon as we sent district representatives, the community were very brazen, and basically said, if anyone comes here, we're just going to torch their car. It was quite sort of confrontational. And I just wondered, in that situation, you know, do we, as health, do we actually just retreat, and not try and engage in a volatile situation, volatile meetings, and just almost go back to the drawing board and start again with sort of smaller engagements, and you know, sort of building that trust again. Thanks.
Thanks so much, Jenny. And Christine, coming back to you, I'm wondering whether you might have some thoughts for Jenny
Yes,
about
I do.
politicians and local councillors getting involved in clinic committees, and what do you do?
Yes, look, the councillors serve on clinic committees on an ex officio position. You know, they can't be the chairperson of the clinic committee. They have no voting rights on the clinic committee. I think it's the selection. How do we select clinic committee members to represent the interests of the community on the health structures? So your community members that you select must be recognized by that particular community. They must have a history of working within that community, so that and it is our responsibility as clinic committee members to foster community support for the health facility. So if you have proper leadership and your leadership is rooted within the community, situations like that, where people want to burn down the clinic and they want to come and burn down the hospital, why should people want to do that if they have representatives, people from the community representing their interest on those structures? Thank you.
Thank you, Christine. And Rajan, I see your hand. Please go ahead.
Thanks, Sue. Yeah, I mean, I will be speaking. I'll have a chance to speak later, so I didn't want to take up more time from other participants. But I just found that those comments and the situation that Jenny Nash had brought up and Christine's response very interesting. So I thought I would just say that, you know, when it comes to trust in communities, I think we have to recognize the correlation between trust and time. You know, it takes a long time. And I think it's a very important point to make, is that we're trying to get things done quickly because there are big problems to solve and they're urgent problems. But it doesn't mean it can be done in a short time, even if they're important. It takes a long time. It means keeping going, even if you do experience situations like that in communities, and to do the work. You know, when I come to my presentation, I'll talk about, we look at trust, the important elements of trust being familiarity, which is proximity and closeness to communities, which you build over a long period. There's accountability to communities and listening to communities, and I think Christine and the other speakers spoke a lot about that. You know, really making communities feel that you are accountable to them, so they feel an ownership of the asset, because you will burn down something that you don't think is yours. So it's trying to ensure that we're accountable and communities see that these assets are theirs. And then responsiveness, which is not just to listen, but to actually respond in a way that makes sense and that benefit communities over the long term. And I think that is really important when it comes to building trust and ensuring that communities feel ownership of assets. Thanks.
Thanks, Rajan. And Natasha, I'm going to take your point and then we're going to go back to you, Rajan, and we're going to hear your presentation. So please go ahead, Natasha.
I think I might be Natasha too. Okay, so Hannah Haricharan, I thought there was a very important point in the chat, and this is this thing about how we understand communities. and how community representatives get legitimacy to actually represent the voice or the viewpoints of the communities. And so for instance, our clinic committees are in all our provinces appointed by the MEC, which is in contrast with, for instance, other participatory structures where they are actually elected. And we have been discussing it a lot, for instance, on the PHM project about creating a national policy. And I hear sort of Christine says those that represent the communities should be people that have worked in the communities for a long time. And that's certainly one way of having legitimacy. But there are other ways, such as, for instance, having structures that are elected by the community. And we have generally chosen an approach which is in contrast with that, where we have a top-down approach of appointing health committees. So I think sort of engaging with those issues of who can legitimately represent communities are important.
Thanks so much, Hannah, and nice to have your participation as Natasha in the webinar. So, colleagues, we're going to now move to our fourth speaker, and coming, I think, with a slightly different set of experiences, because their experiences are not necessarily starting with health, although health is now included. And so I think something that we can all learn for those of us who come more from a health background. So Rajan Woodruff is the director and co-founder of the Bulungula Incubator, a rural development organization in the Eastern Cape. They have nearly 2 decades of experience in integrated place-based development, and they've been recognized for their excellence in education, health, sustainable livelihoods, and youth acceleration. In addition to her work at the incubator, Rajan has served as a director of the Public Investment Corporation and the Government Employee Pension Fund, which is the largest pension fund in South Africa. Thank you so much, Rajan, for sharing your birthday with us today. And we look to your thoughts.
Thanks so much, Sue. Yeah, I'm very happy to be here. Thank you for the invitation, and really great to see that that there's interest in how community-based organizations and organizations that come from deep community embeddedness can influence policy, that there's a recognition that there's something to learn here. And we appreciate these platforms that enable us to give our lived experiences. As Sue said, I represent the Bulungula Incubator. I'm a co-founder of the organization, which is based in the Eastern Cape, on the wild coast of the Eastern Cape, a very remote part of the Eastern Cape. In fact, you can go to the next slide, which will show, for those of you who don't know the Eastern Cape, that we are located sort of very deep in what was the former Transkei area, very close to where Nelson Mandela was born and grew up. And as you know, probably all of you would know that this was designated a black homeland under apartheid, which meant that infrastructure, it was incredibly underdeveloped infrastructure in terms of all government services, whether it was healthcare, no access to healthcare, no access to education, no road that went into the village. Eskom electricity came less than a year ago to the area. No potable water, clean drinking water, no sanitation of any kind. So no cell phone signal even until end of 2019, Cellphone Single came for the first time. So really ground zero in terms of access to any kind of government services that somebody needs to access in order to live a flourishing human life. You can go to the next slide. And our workers and the founder members of the organization we began our work, as Sue said, 2 decades ago. In fact, the very first community project was started in 2004, which was actually a tourism project, which is for job creation and community ownership of a large asset, which still is 100% owned and run by the community to this day. But out of that first project, essentially, we then started the Bulungula incubator, actually because of a health reason, which was the area was in deep crisis, and that's why we talk about this being from a crisis response to sustainable and incremental change. And the crisis was that the child mortality rate was completely off the scale. At least half of the households, 53%, so more than half of the households had lost at least one child to diarrhea from lack of access to clean drinking water. And there were no toilets in the area. And whenever the rains came, and heavy storms, the water sources, groundwater springs got contaminated. And because access to healthcare facilities was so far away, in fact, you have to walk from where we are for about an hour and a half if you're physically fit. I mean, I enjoy walking, I enjoy hiking, I can do it in an hour and a half. Then you have to cross a river in a little local rickety boat, and then you have to walk for another half an hour to get to the local clinic. So think about that if you are pregnant, old, have a disability, or you have 3 children that you have to immunize, or a child who's, has diarrhea, and, or any kind of life-threatening situation. So that was the crisis we were responding to. In fact, 1 in 9 families had lost 3 or more children to diarrhea at that time. And we started the organization just with buying water tanks. So just raising money, and for water tanks, and also just education around what a glass of what looks like clean drinking water can have, waterborne diseases, or can, E. coli, and something that looks like clean water can actually cause illness. And so putting droplets of water under a microscope is really how we started with our education, because there was no access to education in the area. How would you know what E. coli was, how diarrhea worked? How would you know what an immune system was? And so that's where our project started, and everything we've done has come from the ground up. In fact, you can go to the next slide. And the organization then developed from that. These are just some pictures of, looking at where you had schools that were mud structures that had collapsed, and, just looking at some of the water sources that people were using. You can go to the next slide. And we then developed over that period, where we started just with raising money for water tanks, to an organization which now is a holistic place-based development program, which, as Sue mentioned, does projects all the way from education and healthcare, from birth, maternal and child health, home-based care work. We have a Bulungula Incubator Health Point, which is a clinic which is built. The community actually built the original building. That is a rebuild that you're seeing there, but they built the original building themselves with their own resources. They donated the land and raised the funds to build the original one-room clinic, because they were desperate for a clinic, and that was the first community involvement in the in a health program. Now that health point now is a fixed outreach point under the Department of Health. So we are not looking to replace government. We very actively strengthen our partnerships with government entities. The government now, Department of Health now supplies all the consumables, medical consumables, the CCMDD system, which is the HIV ARV medication pickup point, which is located there where the community healthcare workers get the deliveries of the ARVs and deliver them to households where people are not able to, they are elderly or infirm or are living with a disability, able to come and collect their medications, and that the Department of Health actually pays us to do, and also partly funds some of our nurses and our home-based care salaries. So what's very important in the Bulungula incubator model is that we are not trying to crowd out government, and that we enable people in doing policy work, academic researchers. Studies have been done in our area which can inform policy and what kind of healthcare can be done in cooperation with communities. Then, of course, we have an outreach service, which now it goes quite far out of our area into the schools and preschools and communities from here all the way through to Coffee Bay. And again, all those we have relationships with all the clinics that support our outreach services with the medical consumables. And then the home-based care component is essential for healthcare in rural areas. We don't feel that you can actually provide healthcare, decent healthcare, adequate healthcare, if you don't have a home-based care component. In areas where clinics are far away, let alone government hospitals, there are some things that only your home-based care workers who come from the communities, and our other speakers spoke about building trust over time, how you have people who come from the community working healthcare, and that's who the home-based care community healthcare workers are. And that is really where the rubber hits the road on trust. I mean, that's where you get trust from. And one example was, a very good example was during the COVID pandemic, when we actually got quite a bit of media attention for being the first community to have achieved an almost 100% vaccine uptake rate, because our healthcare workers got vaccinated first. And so when they got vaccinated and they went into homes and said, I'm healthy, look at me, nothing happened to me, I'm doing fine, I would recommend it for you, explained what the vaccines were about. We also have a community radio station, Bulungula Community Radio, with DJs who come from the local community, and we have a regular healthcare slot which runs, it's a talk show which runs for 2 hours every day and has interviews with nurses, healthcare workers, and an interactive program where you have questions, research is presented, and people talk about healthcare issues, and so it goes two ways. You can go to the next slide. And another example, which I will come to as well, which was quite important in our integrated, person-centered and community-led program. You'll see it on, I think, on the next slide we can go to. Was an example of where we had an outbreak of scabies in the community. It's quite a few years ago now, almost 10 years ago. And community members were going to government clinics and getting the topical creams that you use for scabies. But the problem was that, there's a whole process of taking all your blankets and all your clothes and boiling that in hot water and clearing out the house and then putting on the topical cream and then waiting for the clothes that you took out to washed yesterday to be clean, and the blankets. And there was a whole process where that community healthcare workers could do door to door with each household. And that's how we eradicated a problem that was just getting out of control in the region, because all the clinics could do was give people a topical cream. And in fact, there'd been some child deaths from organ failure from infections of scratching the scabies. So it was something that government hospitals and clinics, they were calling us and saying, we can't deal with this problem. We need to get the healthcare workers out to do a 3-day process in the households with helping to clear out the scabies, and then we could get on top of it. So to talk about trust, as I said, familiarity, which is proximity and closeness, essentially deeply embedded in the community. Accountability. So accountability is being flexible and listening to the community, because we are located here, you know, and our health care program is made up of people, the family members, and the mothers and sisters of the communities, but also male home-based care workers, which we added because we had you know, male patients and community members say there's some things I want to speak to a male home-based care worker. I only want to interact with a male home-based care worker in some of my health concerns, and so we included male home-based care workers, which was very important to the program and provided a lot of strength to the program. And also in accountability and responsiveness, another example was that in households, our home-based care workers found that they were trained on how to care for people living with disabilities and children living with disabilities, but there was no manual for how does a family take care of a family member with disabilities, and that's different to what a home-based care worker does or a clinic worker or a nurse. So we wrote a manual, which we published in Xhosa with illustrations, made it very user-friendly. This is how a family member takes care of another family member with a disability, because we found there was no literature on it. So that's where the accountability and responsiveness are important. Then it's also important to remember that funders can sometimes have their own goals, and that's fair enough. You might have a funder who is very focused on TB, for example, or on stunting, but that might not be the most important thing for that particular community, because they might have other health concerns, or TB might not be that high in that community, but the funder needs TB stats. So you've got to be careful that, you know, and I've seen that happen in other community-based organizations as well, where you have to take the money because you need the money, but then you're doing a lot more TB testing that you need, and you need to be doing more HIV testing or looking at stunting or not looking at stunting. And so that's where we've got to be very careful as to what we do, because, you know, there's a lot of quantitative data that's needed and can sometimes drive what we do. So I will leave it there. I've got more slides, which I'm happy to share. And whoever's controlling the slides, you could just flip through them for 1 second if you like, so people can see what's on them, and I'm happy to share them. But there's more information about what we mean by familiarity. You can go to the next slide, just what we mean by familiarity, accountability. I've covered all of it, essentially, what's on the other slides, and responsiveness. And then we call our model a three-legged poikie that doesn't wobble. You can go back to that one, the three-legged poikie, because that's the one where it shows that you need the three legs to stand together, which is community, government, and civil society.
Stunning. Thank you, Rajan. And just to link, you didn't talk about your the Bulungula College, but just to link to some of my understanding of that particular experience, where you achieved an astounding matric pass rate when there had been no high school previously in the area. And part of my understanding of what happened there is that the students felt cared for, even loved, and so supported that they were able to do something that was really quite astounding. I wonder if you'd like to comment on that.
Yeah, absolutely, Sue. It's I would say that was essential. You know, we built the Bulungula College. It opened in 2019 because there was no access to high school education at all in the area. Again, we have we now to open in 2019, and just this year in 2025. And so, you know, that we don't continue to build that relationship, and it might take 8.
Can anybody else hear Rajan, or is it just my side?
No,
It's
from
It's not.
outside.
Yeah,
I think
we
it's
can't
lost.
hear her.
You can't hear her. Okay, Rajan, I think your network has gone a bit wobbly. Janine, I see your hand is up. Nice to see
Yes,
you at the webinar.
same
How
here.
are you? Please go ahead.
Thank you for the opportunity and all insightful presentations that I've just had on a topic that is really close to my heart. In fact, I did my work, one of the objectives of my PhD was to kind of design a community-based integrated model for provision of TB, HIV, and PMTCT. Later on, we included other maternal and child health services. So, and that was in 2012. That's when I did. It was a randomized controlled trial, and that's when we're trying the concept of having community health workers who do home-based HIV testing. So, and we at that time we had as well in KwaZulu-Natal the whole operation of Sukuma Sake, which is I think I don't know how many are familiar with that structure, but it's a government or provincial initiative embedded in their structure of governance and community engagement, which was really a good initiative. But later on, I don't know what happened to it. But coming to what the previous presenter just spoken about, my question is, at which point initiative like hers, like among others, where you identify a gap in the health system or in the community, and you're able to build that as an extension of the healthcare system. And I'm also cognizant of the South African context. I'm from Rwanda, but I'm here in South Africa. So with what we did in KwaZulu-Natal, actually, the work that I did contributed to the whole revision of the community health worker program, the policy itself. So when do we determine that this is the time now to shift from a community-based or an NGO to now integrate into the normal health, the mainstream of the health of the healthcare system?
Janine, are you there? I think you were asking a question.
Well, these external funding actually exacerbate the whole vertical system, be HIV and obviously tuberculosis, and now you have as well other emerging. So my question is in terms of health system strengthening, yes, it's good to identify the loophole in the system and start something and gather evidence, but when do you then relinquish and say, now we've tested that this is working, government take over so that there is sustainability? And secondly, what I've learned as well in that part of KwaZulu-Natal and Eastern Cape is most of these organizations were not only funded, but they were more led, I'm sorry to use the racial element, by white. Although we had as well locals in place, but the reality of our people, as you know, they didn't own it per se. They felt that there was a savior who was coming to save, or somebody who has empathy about. There's no problem about race, but unfortunately we have a context that we need as well to be mindful. So how do actors in this space are cognizant of these contextual issues and try to intentionally deal with them to say, you have to own, this is your community, we are supporting, but you should own this process and be the solution. And I think Rwanda has shown quite enough, some good example and evidence where the community health workers are part of the system now. They're being paid, they're recognized, which I think we should, it's an outcry for the continent, where we continue to use this criteria. Very important and there is a provision within our framework of primary health care, but we don't recognize that they need to also be paid. Thank you.
Thank you. Some very, very important points there for all of us to reflect on. Rajan, we lost you towards the, it's going to be difficult to say when exactly we lost you. You got frozen and it was nothing for a while. You were talking about the Bulungula College at the time. Do you want to just finish that off, and then I'm going to pass to Jenny?
Yes, yes. I don't know what happened. It just completely just switched off completely, but then it was came back. So yeah, so what I was saying was that the Bulungulu College, I think it's recognizing that it's not just about the curriculum and about the education, it's about the holistic approach to it. So, it's the clinical services, the outreach nurse who goes every week, provides family planning, support and medications if learners wanted, obviously looking after the clinical needs. And then when we realized we needed to add a mental health counselor, we had to do that. We had to find the budget for it, had to become part of our staff, and so it's looking at the overall needs of the learners, and then also looking at, it's completely illegal, but it still happens in many schools in this region, is that there's corporal punishment that happens, and we said absolutely zero tolerance for corporal punishment. We won't allow it at the Bulungulu College, and our learners, we were told it's not going to work. These at all the other schools said to us, you have to use corporal punishment. We said absolutely not, and we have the best behaved learners in the region, and they're known for that. And so I think it's just showing that that people do respond. It doesn't matter who you are, you respond to love and care, and healthcare has to be part of any development intervention, because you can't just think you're going to get your education outcomes if people don't have access to decent and caring healthcare. And I wanted to just respond to some comments I listened to as I came back, which was just about looking at when you make something part of the mainstream government system, and what is it that can be made part of it. We had some researchers who came from UCT's Chronic Disease Initiative for Africa come and do a study on how people living with comorbidities, and they were looking to survey how people manage to live with TB and HIV at the same time, diabetes, hypertension, and they found something that they weren't looking for initially, but it was so strong in their survey answers, was about what they called the Ubuntu response of the home-based care workers. So it wasn't just about that your child is behind on the immunizations and how can we help you with that. You had community health workers where there were many, many examples of where they were going outside of the call of duty just because they were being helpful. Some of the examples were somebody needed taxi fare, and the community healthcare worker would take it out of her pocket, or she would hold the child or look after. I'm not saying that you can put that into policy, but there is something about the way that care is given that I think we can look at, and we can put into our training manuals, and we can be responsive and accountable and treat people in a way that we can codify. And I think that is what we need to perhaps take from those experiences.
Stunning. Thanks so much, Rajan. Jenny, a quick point, because I want to pass to Krish to give us his wisdom and his wise words to summarize our afternoon together. Over to you, Jenny.
Yes, thanks very much. So I love the Ubuntu aspect, and I think that's something that it doesn't require supply chain management. We need to try and impart more of that into all of us healthcare workers. So my two questions were, when would you decline funding in these tight austerity measures if you felt it wasn't in line, or maybe a community didn't feel that a project or research or funding was in line with your ethos? And then how's your response to the security situation and the potential threat to the Bulungulu incubator? Thanks.
Rajan, do you want to go ahead?
Sure. Yeah, it's a very interesting question in terms of declining funding. I mean, obviously it's on a case-by-case basis, right? And so we've actually started to work with funders, and we've been fairly successful is in talking to funders who are starting to understand what trust-based philanthropy is about, and that it's not about deciding what your strategy is first as a funder, and then trying to find organizations and force them into into your square holes. But that if you want to make real impact as a trust-based funder, is to do your due diligence on organizations that you think are good partners, and you can put us through a very rigorous due diligence process. In fact, trust-based funders spend a lot more time on the due diligence process, where they come on site. You've got to fill in many forms. You've got to supply an enormous amount of background information, and they do their reference checks really well, and they spend a lot of time on that. And once they are happy with the work that you do, they then give you the money to do what you do best. Now, it can be that they want to focus in the health area, they want to focus in the education area. We understand that. But then allow us to, for example, give you the education outcomes that you want. That might be your early childhood development measures in preschool, or you might be your number of immunizations. We can give you those numbers, but don't force me to spend X amount on transport, because that's what I said I was going to do in the budget, because it might be that we need to be flexible and the transport money is not needed right now because Department of Health came and offered us a vehicle, so we didn't use it. So that money could better be used for a new alcohol harms pilot program that we're doing. And that's where the person-centered approach comes from. So just to give you just one example that comes to mind, we had the nurse come to me recently and say, oh, there's a grandmother who's saying that she can't collect her HIV medication, and she can't take it because there's no food in the home. So we need to, because they need to get the social grant sorted out, and so we need to get a social worker to do that. So we spoke to one of the home-based care workers, and said, can you help this grandmother to go and sort out her social grants? And the home-based care worker said, the community health care worker said, that's not the problem. The grandmother needs to be on the alcohol harms program, because alcohol is the problem in the home. And so you can work with what is actually the problem in the home, not what you assume is the problem in the home. And so that's very important in being person-centered. So I think those are very important issues to focus on. When we're thinking about policy responses. And then to talk about the security situation. So
And
the
then I'm
uh,
worried about time.
okay. I'll just say that the community have solved the security situation. That's the short
Oh,
answer.
love that answer. Thank you. So, colleagues, I want to pass back to Krish for his wisdom and final messages. But thanks again from my side for all the wonderful engagement on this webinar. Krish, over to you.
Thanks very much, Sue. Thanks, colleagues. Oh, wow, what a wonderful panel and what a excellent set of inputs. I'm probably not going to do justice in summarizing it all in great detail, but just very quickly, some of the key messages. I think the big thing for me was that, community engagement is not a nice to have, and it's not a soft kind of issue that, it's a luxury. What colleagues have actually shown is there are very tangible benefits and real gains you can make by having good community engagement. So that's a big message for me. The colleague from NACOSA, I think I really liked the framework of education, evidence, engagement, and advocacy. It's a very nice way to think about it. And I think the issue of co-creating solutions is important with communities. The colleague from Limpopo, I think, very nicely brought out some very basic things: to be respectful in the way we engage communities and paying attention to right from dress code to language to those kinds of things in the way we engage communities, and also not over promising and under delivering, because that breaks down trust. Christine, I think, really reminded us about that it's not an easy journey. It's a difficult journey, but it can be a very constructive one, making solid gains in building this relationship between frontline state actors and facilities and communities, and moving from the apartheid era to a very different dynamic post democracy. I think the point about the aptitude of people frontline having the confidence and the training to be able to engage and how they do that. I think that's an area we often neglect and assume that should be there. And I think that's an incorrect assumption, and we should pay attention to that. I think the issue of gaps in the statutory frameworks where it doesn't make provision for integrated governance, right? So, yeah, I think Christine made the point about the district health council legislation doesn't connect to clinic committees, doesn't connect to hospital facility boards, and so it's fragmented in itself, and that doesn't foster for integrated governance. I think the big point about communities are not homogeneous entities, and there can be power dynamics and divisions in communities is something that we also need to be quite mindful. I think the point about credibility of the voices from communities is quite an important one, and how those voices are selected, how do they report back to communities, etc., is important. Then Rejan, I think the whole Bolongula project I think this is the second time I'm listening to this input. It's really such an inspiring input. It's such a inspiring project because it's integrated holistic development. And that's what the original conception of primary health care was also all about. And you often sometimes read that and you think it's just not possible to happen in this current context with where we are at. And then you listen to a project like Bolongula and you feel very, very inspired and really taking a very developmental perspective. I really like that three-legged poiki of working with communities, government, and civil society. And again, you've also given examples of very tangible benefits and results from working closely with communities, whether it's disability, whether it's vaccine coverage, and the like. Then some of the colleagues from the chat groups also raised important points. I think building the relationships with communities in peacetime can hold us in good stead during crisis time. I think it was Reno who made that point, very important point. And Janine's point about how does one move some of these externally funded initiatives to the mainstream so that we can actually sustain those, and how we deal with funders in that regard are also important points, particularly in this current context. So that's my quick summary of messages, but all in all, it's very inspiring set of inputs that really community engagement is still a very important pillar of our work, and we need to pay more attention and some very practical lessons of how we can do that. So thank you very much to all our speakers. Really very powerful inputs. Sue, thank you for doing an excellent job at facilitation and holding this together. And really to the webinar, there's an organizing group in Salad that pulls these things together. So thank you very much to all of them. And lastly, we've had between 60 and 70 people attend this. So really thank you to all for making the time and making this such a fruitful, constructive engagement. We're going to be having other webinars. Carissa, I don't know that it's not screen showing on my screen, but there is a QR code for where all these webinars are hosted. And these are all the people I'd like to thank. I've mentioned that already. There's the QR code. You can get into any of the webinars we've hosted previously. Just 2 dates coming up, 15th of October and 26th of November. The topics will be announced soon and the themes. And if you want to join the Salad mailing list, there's Carissa's email address. And if you want to join the PASA HPSR, the Health Policy and Systems Research listserv, Tumelo is the point person for that. So colleagues, well done, and really thank you very much to every one of you. Thanks, Sue.
Thank you, Krish. And we'll see you at the next webinar, everybody. We wish you a very good evening. Bye for now.